that because it's a handheld ligature device, so actually connect the Valley Lab. So I normally use handheld 10mm ligature. It's got a hand control on it, so it should be connected. We used to use gentamicin and metronidazole, yeah.
That you are utilizing Dr.
Dr.
Sohail, what is the dose that you are giving? 80 milligram gentamicin?
That's correct, yeah, and 500 or a gram of cefuroxime, yeah. Is this top or side?
Top.
Bottom? Side.
Side.
I normally use a sticky drape. It comes in the shape of a Lloyd Davis pole. So it's a one drape, and with a big hole in the middle, and which got sticky corners. So you put whole one drape, and the legs go over, and so it's just one single drape. I think it's a 3M ethicone drape. Yeah, move it a bit forward, come it a bit more. Yeah. Thank you. So the port side placement would be, like I said, I do a cut down. I normally do a supraumbilical cut down, put one port there, one there. Yeah, let's set up the cameras. So you've got a stored set. Right, this is very high, isn't it? Yeah, the monitor.
Yeah, monitor is high.
Yeah. So we are just prepping and draping the patient at the moment, setting up. Normally most places where I work and some of the places around it have got what we call ceiling mounted monitors. So all the monitors are stacked, everything is mounted on the ceiling, so there is nothing on the floor. You can move all the monitors around you. This monitor is okay, slightly high, so if it's a long operation, if you're doing a long laparoscopic procedure, then you're looking at the monitor like that all the time. You get a bad crook in your neck at the end of the day, but I mean hopefully it should be okay. I could just turn it around to me. A bit more, that's it. So I put a supraumbilical cut down, CO2, then I put one port near the endoscopic spine, one possibly suprapubic, one port opposite there, and then we can start working around. 30 degree. आपके पास squiver है instruments डालने के लिए? Do you get a pouch? Right, shall we start? Can you start?
Good. Start कर. 30 degree. White balance करना.
Okay, so we're going to have to put our instruments on here, aren't we? A bit of a antibiotics are in, yeah? Both of them? Okay, chale. Are we all right to start? Right, can you see us? Can you see us in the audience?
Yes, Dr. Sohail, we can see you.
So we'll just do
you will use open method for creating pneumoperitoneum?
I just use a cut down. I just use a Hassan's cut down maneuver. I've never used Vera's, so I'm not comfortable with it. I just do a cut down for all my laparoscopic operations, gallbladders, hernias, or whatever. Yeah. Have you got Langenbachs?
Langenbach चाहिए तो
Have you got bigger Langenbachs here? बड़े वाले हैं? Can we just use them? Have you?
बड़े Langenbach भी चाहिए अभी रख लें.
Let's use the big ones. One for you, one for me. Yeah, clip and I'll just need 3 clips. Just keep moving forward. So I don't know whether you can see or not. We are onto the sheath now. So I normally just cut through the sheath. You can see the extra peritoneal fat. I stop there. You just give me a clip. Have you got a heavier, bigger clip?
Heavier.
So grab the sheath, take your Langenbach out. One for me, and the third one, another one.
Knife passes.
I just need a clip now. Have you got a clip? No, big one. Ji. Just passes a swab. Sorry.
Forceps.
Okay. Trocar. Trocar.
Without.
नहीं इसके just yeah, there's a sharp trocar, blunt trocar. Okay, gas on.
Yes, one. Asif.
You want to come on this side, Sharia? What is the pressure on the insufflator? $15. Okay. Normally I use 15 mm of mercury for most of my most of the procedure. We use a 30-degree camera, so when the cable is up. Shari, are you familiar with the use of 30-degree, aren't you? You familiar? Yeah. So basically, when the cable is up, you'll
Is
Yeah, when the
15
cable
degree
is up, you're
pressure
looking down.
ideal for all laparoscopies or it's only for hemicolectomies?
No, basically 15 mm of Hg is just an empirical procedure. So we, if the patient, for example, are be guided by the anesthetist, if they have problems, if they develop bradycardia, or if they have got a poor chest, then we put the pressure down even to 10, 12. But more than often, I will use I would use 15 mm of Hg. Why let's say white balance. Just give me the swab. एक swab दीजिएगा जरा. Swab, sorry. It's just saying white balance. So can you see the laparoscopic view?
No, yes, now we can see
You
the
can that. So
laparoscopic
just,
view.
You just pop the laparoscope in, and just have a little quick look around. It's important to look at the stomach, which is deflated. Sometimes it gets inflated. Sometimes they get the stomach inflated. But these chaps have managed to keep it deflated. I don't use a nasogastric tube routinely. Has he got a nasogastric tube? Yeah, okay, that's fine. Even if I use it, I use a orogastric tube just for the duration of the operation. So just having a quick look around, and then we'll see what happens. Obviously, he's got a reasonable greater momentum, so we'll just put his head and down, please now, head and down. So we'll put his head and down, and you will hopefully see the things slipping away. Yeah, keep going. Keep going, keep going, keep going, keep going, keep going. Don't worry, you won't slip. Keep going. Keep going, keep going, keep going. Yeah. Keep going. Okay, let's stop for a second. So we are, like I said, we do use extreme head down. Just give me side to side tilt. Right side up, please.
Right side up.
So positioning of the table is very, very important for all laparoscopic procedures. It just seems a bit bright, isn't it? Sorry, I'm just trying to set up the experimenting with this camera a little bit. Ah, that's it. Let's just give me the white balance again.
You are using a high definition system.
Sorry?
You are using a high definition system.
Yeah, yeah. Okay, so yeah, just give me your right hand, tilt up please. Yeah. So just trying to position the patient. Stop. Okay, so you can see the cecum is slightly fallen over. Then we'll put some more ports in. Do you want to put the ports in or? Okay, so I'll start off with my right sided, so I'll use the 10-12 here please. So it's near the, I don't know whether you can see it, it's near the anterior superior iliac spine, slightly higher. That's where I normally put my 10-12. And a 5 please.
So this port is also 10 mm?
Yeah, 10-12. This is a 10-12 port as well. And then next one, I normally put umbilicus ki line mein, slightly higher, so my hands don't clash. It's very important to put ports at a ergonomically advantaged position, so you're not fighting with your assistant, you're not clashing, your hands are not clashing all the time, because so that's a 5. Let's pull it out, Sharia. Pull the camera out. Thank you. Couple of Johans. Right. Do you want to look at the cecum now, please? So just what I suggest you do, if you don't mind, just keep it like that. So basically, so when the cable is up, it's with the 30-degree, as probably most of you are already familiar. When the cable is up, the camera is looking down. When you put the cable on the right, the things look to the left and vice versa. When you're looking obviously down, the cable looks at the abdominal wall. So let's see where this tumor, can we just dim some of the lights, background light, please? No, it's not that great. Normally I use, I don't know what we use to clear the lens. Normally I use something called Fred, F-R-E-D. It's just sort of a detergent which keep the lens clean and keep it warm. I mean, the picture is reasonable, it's not that bad. So let's pop the things in and see where this guy's tumor is. So that's his cecum. These are atraumatic on there.
At presently, you are working with 2 ports.
Correct. Presently, I've got 2 ports and, well, 3 ports. 1 port is the camera, but you're right, yeah. I've got 2 working ports. You can see he's got some feces in the cecum, which is fine. We haven't given them bowel prep. You can see the appendix, terminal ileum. Just look up, please. So he's got some adhesions there. We need to, when we start this procedure, we need the omentum. Just give me a profile. That's it. We need the omentum. Can you open the ligature show? We need the omentum to go over the liver, right? It's more so important in the left resections or pan-proctors. So could you show them the greater omentum on the right side, please? So you can see that with a little bit of head and change, there's a transverse colon coming up there, and we lift up the greater omentum. Just look down, please, Sharia. We try, see if it's attached down to the, just have a look to the left of the screen. Yeah, keep looking to the left, and down, and down. There, you can see the greater omentum. I'll try to lift it up. I don't want to try too many, I don't want to try extreme head down because I haven't got my usual bean bag. So I'm not very comfortable, but this is good enough for the moment. So that's a greater omentum. You can see that I'm trying to push it over the liver. So you can see the transverse colon, which you should be able to see shortly. That's the transverse colon peaking there on the left hand side of my screen. And then Shahryar is moving toward the spleen. Keep going, Shahryar. Okay, and we are just lifting up. You can see the transverse colon peaking down now, and we just try to lift the greater omentum up. Okay, keep looking. Okay, so that's almost up to the, I think, in the territory of mid colic. So we lift all the greater. We can see the transverse colon nicely. Look to the right, please. I beg your pardon, look to the right of the screen, screen, yeah. Keep looking. So we just lift it up as much as possible, and then you are in the splenic flexure region, which obviously we don't want. So just trace the hepatic flexure back, keep tracing it back. So we're tracing the hepatic flexure back, that's the, we're tracing the transverse colon back, that's the hepatic flexure. Look to the left, please. So we haven't seen any we haven't seen any serosal changes on the cecum. We haven't. The CT suggested that it's a large tumor which is going from the cecum into the ascending colon, but we haven't seen any serosal changes just quite yet. Look down, please, Sharia. So we just get this small bowel out of the way. I normally, if you put extreme head and down, that's why I don't use extreme head and down for the right hemis, because then the small bowel will come in your way. So if you see, this is probably good enough. You see the small bowel has just fallen nicely into the pelvis, and this is the terminal ileum there. Maybe a slight degree of serosal erythema, but there are no true serosal changes. Right, I'm just going to put another, you opened the 5 millimeter, right? I'm just, no, yeah. I just put another 5 millimeter port in. Now where should we put these, because it's going to fall down, aren't they? Aapko deta raha hu. Right, Shahriyar, can you just show me this, please? Just put the cable down so you're looking up. Put the cable down so you're looking up. But the head of the camera should be facing up. No, up. That's it. So pull your, that's it. That's a good view. So you can see the good view of the pelvis, and we'll just put up 5 in.
Dr. Sahil, where are you putting this port?
Cameraman, can you show them? Can you see me now?
Yes, we can see.
Right at the suprapubic. This is a suprapubic port. Okay. So right at the sort of slightly above the symphysis pubis, on top of the sort of bladder region. Could you do me a favor? Can you give me? Well, let's start with the 5 milligram. So the energy device of my choice, is it connected? 2 bars, yeah. The energy device of my choice is LigaShow. No special reason why I don't use harmonic. I'm just used to LigaShow. That's how I was trained, and since then I've always stuck to it. So just give me your hand, please. Right, what we need to do, Shahriyar, we need to find the alucolic pedicle. So what I want you to do is take your hand. Have you got another your hand?
Yeah.
Right, and just you need to just pull it out as much as you can. Right, that's good. So that's you. You can see the duodenum there peeking through right there, but we'll get to that in a second. Shahriyar, you need to hold this as well. Okay, can you just open and close it so you get familiar with it? You see the tip? Yeah, that's good. It's not obviously it's not right, is it? It's not. The jaws are not closing properly. Just give me another your hand, please. Right. Okay. So we should start. Right. What the approach that I use is a medial to lateral dissection. Most laparoscopic surgeons, as you know very well, for traditional open right hemis, we would do a lateral to medial dissection. Since we have started doing it laparoscopically, we go the other way, a medial to lateral dissection. There are several reasons for it. Laparoscopically, probably it's a bit more convenient. So that's what I do. I do a medial to lateral dissection. So what I'm going to do first, I'm going to take those adhesions down. Can you show me those adhesions?
Is it something like that we have got a more vascular control from right to left?
Beg your pardon?
Median? Is it more like that you have got a good vascular control when you are moving from medial to lateral side?
Yeah, that's very correct, yeah. Just go in, Sharia. I'm always when I'm doing this maneuver, I'm always very mindful of bowel. Obviously you can clearly see there's no bowel here. I do a lot of incisional hernia surgery, laparoscopic big incisional hernias, and sometimes there are redos and there are always bowel stuck. I never use an energy device when I'm doing a laparoscopic incisional hernia repair. But obviously this guy has got a virgin abdomen. He hasn't had any previous abdominal surgery. So just go in, Sharia. Look to the left here. So I don't know how many of you guys use LigaShow. LigaShow is a bipolar diathermy. Unlike harmonic works by sound waves. It creates heat. Harmonic creates heat by vibration of two crystals. LigaShow is totally different. It uses bipolar. One of the reason I slightly prefer ligashore over harmonic is the fact that the tip doesn't get very hot. I don't like harmonic because the tip get very hot sometimes, and it can cause thermal injury. I mean, the tip in ligashore gets hot as well, but not as much as a harmonic. Look up, please, Sherry. Sherry, just focus it a little bit for me, please. I'm just taking these adhesions down. I'm not doing anything. I'm just taking these down because, yeah, that's good. That's what the problem was, wasn't it, all the way along? So we are slightly out of focus. We have corrected. That's one of the problems with laparoscopic surgery. You have to be mindful of most factors, things going around you, and that's why it's slightly more stressful because you have to be eventually be doing most things that other people will take responsibility for in open surgery.
Dr. Sohail, can you tell us what is the level of adhesions because the view is very much limited?
Oh, I'm sorry. This is hepatic flexure.
Right, thank you.
The hepatic flexure is just stuck up onto the anterior abdominal wall. The ligashore can just cut as well. Sometimes I don't burn. I just cut with the ligashore. Okay, so we are going to go, we'll start our medial to lateral dissection. We'll find the ileocolic pedicle here. Shahryar, my assistant, he's got control of the left upper quadrant port. So he's going to help me out while I localize look up Shahryar for a second, don't use your port yet. While I localize the ileocolic pedicle. So this is the terminal ileum cecum. You can see it clearly. That's the ileocolic pedicle. All right. Okay. You can see the ileocolic pedicle being tented up.
Are there any landmarks for locating it?
Yes. Basically, just look up. Show them the ileum. Yeah. So this is the ileum. This is the cecum. There's the ileocolic valve. I normally grab it there. Try not to handle the tumor too much. Try to go around the fat. So you can see it tented up now.
Yes.
Just look to the right, please. Now tell Shahryar, just rotate the camera to clockwise, just rotate. No, the whole thing. Yeah, keep rotating, keep going. So I want to put it transverse so that you guys can see and we can see. Now this is the greater momentum coming out of the Shahryar is going to hold that. Shahryar, pull the camera, yeah, that's good. Pull the camera out. Yeah, grab it and push it away. So Shahryar is pushing it away and I am looking there and that's you can see it coming off. You can see it going there. There's the superior mesenteric vein there, and the superior mesenteric artery is going to be there, where the tip of my ligashore is. That's a duodenum. Yeah, can you see the duodenum there? Right there.
Yes, we can see.
Yeah, I'll show it to you in a second, and then that's the bowel. So we'll start our dissection. What I normally do, I grab hold a little bit more of the ileocolic pedicle, so it's under tension, and then I start the dissection.
The pedicle contains both vein and artery?
Beg your pardon?
Pedicle contains both vein and artery?
Yes, correct. Yeah, it's the ileocolic pedicle. Yeah, so it's contained both of them. So make a little nick there in the peritoneum, and then work underneath it. Now there's always an oncological debate that rages as to where you take the vessels, and I mean, obviously, as you guys know, that most people will say that you need to harvest at least minimum of 12 lymph nodes to stage the tumor properly, right? So I think that's what a surgeon should aim for, because you don't want to overstage them, you don't want to understage them. You want to harvest a reasonable amount of lymph nodes. So the closer you are to the vessels, the more lymph nodes you will harvest. So I don't go mad. Just look down. I don't go mad on trying to go too close to the vessels, but to the origin of the vessels. But I like to be as close as possible. But it's important to make sure that you have a decent number of lymph nodes. So I'm just cutting the peritoneum overlying the vessels, and I'm hoping to find the vessel in that process. And it's a matter of getting into the right plane. Could you open a 10 millimeter ligashore as well, please? Yeah. Now, if this is the correct plane, if you are in the correct plane, you should be able to see the duodenum shortly. It should be on there. Obviously, at this stage, what you are trying to save is the duodenum. You don't want to damage the duodenum. So I try not to take the vessel till I've dissected underneath it and seen the duodenum myself. Show me. Look up there for a second. Just grab hold of this bit. No, this bit. Take your hand out. Pull your camera out. Just be very gentle. Yeah, just grab this area. Okay, I'll help you with that. Yeah, that's right. Just put your hand on there. Just close the jaws. Yeah, that's right. You don't even need to grab it. Just close it. That's it. Beautiful. So we got plenty of tension now there, and we'll see if you can see the duodenum. It should be coming up over there somewhere. That's probably peeking through. You can see the duodenum now there, right? So the duodenum is peeking through. So we need to stay above the duodenum, obviously, in order not to damage it. So that's what my plan is. As long as you stay above it, you're fine. You can just see the duodenum there. Ooh. Have you got a suction? Yes. Right, you can see that we've encountered some bleeding. We'll try to see if we can control it. Yeah, just give us a second. Okay. Let's put it on.
Upward.
Sorry? ये बटन है शक्कर का? It's not working. Oh, it is. Sorry. Probably is a vein underneath there, but I think I've got my harmonic on top of it. So could you just swap it with a 10 millimeter now? Pull out area. Suction, please. Passes the suction. Okay, that's about 10 millimeter now. Got pouch, no, that'd be a good idea. You can just stick the instruments your person. So I'm just going to swap my lager to 10, see if I can take this vessel. I'm reasonably happy because, just pass me the sucker. I'm reasonably happy because I can see the duodenum. You've seen that we had a little bit of bleeding. I normally take the vessels with the lager shore. Okay, thank you. Is it connected? Yeah. We'll go with the big boy now. This is a 10 millimeter lager show. Okay, is it connected? जहाँ पे पहले था वहीं पर लगाइए. Just swap it.
You are just walking over the vessel?
Sorry?
You are just walking over the vessel?
Walking over the vessel? No,
Means you
I'm just gonna diaphragmize the vessel.
Okay.
Yeah, are we connected? Digital scanner. I don't know what that is. Let me just try it. Just take it out and put it back in. दूसरा आप निकाल लिया ना आपने जो पहला वाला था. Just switch it off and on. Just switch it off. Switch it on again. Switch it on again. जो पहले वाला था वो ऊपर लगा हुआ था या नीचे? तो फिर इसको भी आप वहीं पे लगाएं ना. Why are you swapping it? यहाँ पे 5 millimeter लगा था, वहीं पे भी इसको लगाएं. Exactly the same thing. Sorry, we are just trying to fix up our 10 millimeter port. AC. AC. He's talking about AC. Yeah, thank you.
AC, air conditioner.
Look down for a sec. Sucker, please. Sucker. Why don't you come on my left hand side? आप मेरे left hand side पे आ जाना, then it will be easier for you to give me all the stuff. Yeah. तो suction यहाँ पे लगा दें. I'm just trying to develop the plane in the duodenum that I was trying to show you and see where that plane is. So we encountered a little bit of bleeding, so now that seems to be under control. So we'll just go back to our landmarks and try to start everything again. And I think the bleeding was from a superficial vessel, so we try to develop the landmarks again and see if we can make some sense of it. I'm not obviously a little bit familiar with the suction device. It's not what I normally use, but there you go. But I think that is the vessel there.